Question 1. A 58-year-old male with a history of hypertension is found to be confused and cool to the touch. Vital signs are BP 82/60, HR 124, RR 22, SPO 294%. His skin is pale and clammy. This patient is most likely experiencing what stage of shock? A. Decompensated progressive shock. B. Compensated non-progressive shock. C. Irreversible refractory shock. D. Distributive shock. Answer: A. Decompensated progressive shock. The concept tested here is the stages of shock, which is defined by the body's response to poor perfusion. The keywords are confused, cool to the touch, and, critically, the blood pressure of 82/60, which indicates hypotension and a failure of compensatory mechanisms. Decompensated shock is characterized by a significant drop in blood pressure and altered mental status because the body's attempts to maintain perfusion, like increasing the heart rate, are no longer successful. For example, a young patient who is still fully alert and has a normal blood pressure despite significant blood loss would be in compensated shock. Always remember that a drop in blood pressure is the definitive late sign of shock, signaling that the condition has moved from compensated to the far more dangerous decompensated stage. Question 2. You have successfully intubated a patient and are monitoring their capnography waveform. The waveform suddenly changes from a normal square pattern to a shark fin appearance, and the exhaled carbon dioxide reading, ETCO2, is trending upward. This change most likely indicates A. Esophageal intubation. B. Partial obstruction of the endotracheal tube, ETT or bronchoscope. C. A sudden increase in cardiac output. D. Bronchospasm or COPD exacerbation. Answer: D. Bronchospasm or COPD exacerbation. This question tests the interpretation of capnography waveforms, a critical skill in advanced airway management. The keywords shark fin waveform and trending upward ETCO2 are the key clues for airway resistance issues. The shark fin pattern occurs because the patient has difficulty exhaling due to narrowed airways, like during bronchospasm, causing the exhaled gas to take longer to reach the sensor and creating a slow, sloped upstroke. Esophageal intubation would show no waveform at all, and a partial tube obstruction would typically show a decrease, not an increase in ETCO2. Recognize that the shark fin pattern is the classic indicator of increased resistance, such as a severe asthma attack or COPD exacerbation, which slows the smooth exhalation of carbon dioxide. Question 3. A 35-year-old female presents with a chief complaint of racing heart and lightheadedness. Her cardiac monitor shows a regular narrow complex tachycardia at a rate of 190 BPM. Initial attempts at vagal maneuvers have failed. What is the most appropriate next step in management for this stable patient? A. Immediate synchronized cardioversion at 50 joules. B. Administration of amiodarone 150 mg for over 10 minutes. C. Administration of adenosine 6 mg rapid for push followed by a saline flush. D. Administration of 4-access and immediate transport. Answer: C. Administration of adenosine 6 mg rapid for push followed by a saline flush. The concept being tested is the management algorithm for stable narrow complex tachycardia, also known as supraventricular tachycardia, SVT. The keywords stable, regular narrow complex tachycardia, and vagal maneuvers failed point directly to chemical cardioversion as the next step. Adenosine is the first-line pharmacologic treatment for stable SVT because it temporarily blocks the AV node, often interrupting the circuit and restoring a normal rhythm, and it must be given rapidly to reach the heart effectively. Synchronized cardioversion is reserved for unstable patients, while amiodarone is typically a second-line or antiarrhythmic option for other rhythms. Remember that adenosine must be delivered with an immediate saline flush to ensure the drug reaches the central circulation and the heart quickly. Question 4. You are called to a 72-year-old patient who fell from a ladder. He has clear angulation and deformity to his right forearm and is complaining of severe pain. He refuses transport, stating, "I'll just drive myself to the clinic." He is alert, oriented to person, place, time, and event, and denies any head injury. What is the most critical element to establish before accepting this patient's refusal of care?
A.
That a police officer is on scene to witness the refusal.
B.
The patient is informed of the specific risks of refusing treatment and transport, including permanent disability.
C.
The patient has insurance coverage to pay for the private transportation.
D.
That the patient is not under the influence of any prescription medications. Answer: B. The patient is informed of the specific risks of refusing treatment and transport, including permanent disability. This question addresses the legal and ethical concept of a patient's capacity to refuse care. The keyword "most critical element" emphasizes the need to establish informed refusal, not just lucidity. A patient can be alert and oriented, but still lack the capacity to make an informed decision if they do not fully understand the consequences of their refusal. Therefore, the EMS provider must ensure the patient clearly understands the potential risks and complications, such as a compound fracture or permanent loss of function, associated with refusing evaluation and transport. The patient's comprehension of the consequences is the standard for capacity, which is crucial for protecting both the patient and the EMS provider legally. Question 5. A patient has sustained a significant blunt force trauma to the head. Paramedics note the following vital signs: blood pressure 180/102, heart rate 48, and an irregular, deep breathing pattern by its respirations. This combination of findings is known as
A.
Beck's triad,
B.
Cushing's triad,
C.
Starling's law,
D.
sepsis triad. Answer: B. Cushing's triad. This question tests the recognition of a classic sign associated with severe increased intracranial pressure, ICP, following head trauma. The keywords are blunt force trauma to the head combined with the specific critical vitals: hypertension, increased BP, bradycardia, decreased HR, and irregular respirations. Cushing's triad is the physiological response to rising ICP as the body attempts to force blood into the brain against the high pressure. Beck's triad, JVD, muffled heart tones, and narrow pulse pressure, is associated with cardiac tamponade, not head injury. Recognizing Cushing's triad is a life-saving clue that signals impending cerebral herniation and requires immediate, aggressive management of the patient's airway and blood pressure. Question 6. Which of the following scenarios is the most appropriate indication for establishing an interosseous IO access site in a pediatric patient?
A.
A 6-year-old in respiratory distress who requires 4 antibiotics.
B.
A 10-year-old with status epilepticus whose peripheral 4 attempts have failed after 3 minutes.
C.
A 1-year-old patient in traumatic cardiopulmonary arrest with no accessible peripheral veins.
D.
A 3-year-old who is dehydrated from vomiting and cannot tolerate oral fluids. Answer: C. A 1-year-old patient in traumatic cardiopulmonary arrest with no accessible peripheral veins. The concept is the proper indication and application for interosseous IO access, particularly in pediatric emergencies. The keyword "most appropriate" highlights the time-critical, life-threatening scenarios where this technique is necessary. IO access is specifically indicated when a patient is critically ill or injured, e.g., in cardiac arrest, severe shock, or status epilepticus, and peripheral intravenous access cannot be established rapidly, typically within 60 to 90 seconds or after 2 failed attempts. A patient in cardiopulmonary arrest represents the most extreme time-sensitive situation, making the lack of vein access the strongest indication for immediately proceeding to the IO route for fluid and medication administration. Remember that IO access is an emergency measure for vascular access when immediate delivery of life-saving interventions is required and standard methods have failed. Question 7. A 28-year-old G1P1 patient has just delivered a healthy baby. Approximately 10 minutes post-delivery, you note heavy, persistent vaginal bleeding that is saturating several pads, and the uterus feels boggy, soft, upon palpation. The most crucial initial step in managing this postpartum hemorrhage is to
A.
immediately administer 2 liters of crystalloid fluid wide open.
B.
Perform continuous fundal massage to stimulate uterine contraction.
C.
Insert a large bore peripheral 4 and administer oxytocin, pitocin.
D.
Place the patient in the Trendelenburg position. Answer: B. Perform continuous fundal massage to stimulate uterine contraction. This question focuses on the immediate management of postpartum hemorrhage, PPH, a life-threatening obstetric emergency. The critical keywords are heavy, persistent vaginal bleeding and boggy uterus, which together indicate uterine atony, the failure of the uterus to contract. Since the vast majority of PPH is caused by atony, the most crucial and immediate non-pharmacological action is to perform a vigorous, continuous fundal massage to manually stimulate the uterine muscles to contract. While 4 fluids and oxytocin are important, they take time to administer and work, whereas manual massage provides instant, direct intervention to stop the bleeding by shrinking the uterus. This initial hands-on action is always the first, most direct intervention to control bleeding from uterine atony. Question 8. Which of the following patient presentations represents an absolute contraindication for the use of continuous positive airway pressure, CPAP?
A.
A patient with acute pulmonary edema with a BP of 140/90.
B.
A patient with a history of COPD and mild confusion.
C.
A patient in severe respiratory distress who is actively vomiting.
D.
A patient with a documented history of claustrophobia. Answer: C. A patient in severe respiratory distress who is actively vomiting. The concept tested is the appropriate use and contraindications of non-invasive positive pressure ventilation CPAP. The keyword absolute contraindication refers to a condition where the treatment should never be applied due to high risk. Active vomiting poses a massive risk of aspiration because CPAP masks are tightly sealed, making it impossible for the patient to clear their airway while the pressure is being applied. While mild confusion or claustrophobia can be relative contraindications, the inability to protect the airway, such as from active vomiting, is an absolute contraindication that necessitates a different airway strategy. Always remember that any patient who cannot protect their airway, whether due to vomiting or significant decreased level of consciousness, should not receive CPAP. Question 9. During a complex vehicle extrication in a remote location, you discover several containers labeled with a diamond-shaped placard indicating a highly corrosive material. Which action is the most appropriate for the initial EMS crew?
A.
Initiate immediate patient care and decontamination using copious amounts of water.
B.
Place the patient on the stretcher and expedite transport to the nearest facility.
C.
Establish scene safety by using binoculars to read the placard and consulting the emergency response guidebook, ERG, from an uphill, upwind position.
D.
Immediately move all vehicles away from the scene and establish a triage unit 50 feet away. Answer: C. Establish scene safety by using binoculars to read the placard and consulting the emergency response guidebook, ERG, from an uphill, upwind position. This question tests the priorities and procedures for hazmat incidents, which must always begin with crew safety. The keywords are highly corrosive material and initial EMS crew, which mean the scene is immediately dangerous and requires careful assessment before action. The first priority is always to ensure safety and avoid contamination by viewing the scene from a safe distance, often uphill and upwind, and then using the ERG to identify the hazardous material and determine the necessary isolation zones. Immediate patient care or decontamination should only begin once the material is identified and the area is confirmed safe, or the patient has been moved to a designated hot zone to cold zone pathway. Here is a helpful tip. In a hazmat situation, the first and most crucial step is always to protect yourself and others by identifying the substance and establishing the proper exclusion zone. Question 10. A patient in refractory ventricular fibrillation VF has received 3 defibrillations, 2 doses of epinephrine, and 1 dose of amiodarone per ACLS protocol. Following the next rhythm check, the patient remains in VF. What is the appropriate next pharmacological intervention?
A.
Administer a second dose of amiodarone.
B.
Administer lidocaine 1 to 1.5 mg/kg 4/IO.
C.
Administer a third dose of epinephrine.
D.
Administer a high-dose epinephrine bolus 0.2 mg. Answer: A. Administer a second dose of amiodarone. This question tests the sequencing of drug administration in the adult cardiac arrest algorithm, ACLS, specifically for shockable rhythms like ventricular fibrillation. The keyword refractory means the rhythm is persisting despite initial standard treatment. After the first dose of amiodarone or lidocaine as an alternative, the next drug scheduled in the sequence is the second dose of amiodarone at 150 milligrams. Epinephrine is repeated every 3 to 5 minutes throughout the arrest, so a third dose would only be given after the next 3 to 5 minute period has elapsed. A helpful way to remember the sequence: in VF/pulseless VT, epinephrine is standard and amiodarone or lidocaine is the antiarrhythmic drug given after the third shock, followed by a second antiarrhythmic dose after the fifth shock. Question 11. You are performing CPR on a 7-month-old infant. You are working as part of a 2-rescuer team. What is the correct compression to ventilation ratio for this patient?
A.
30 compressions to 2 ventilations.
B.
15 compressions to 2 ventilations.
C.
15 compressions to 1 ventilation.
D.
Continuous compressions with 1 ventilation every 6 seconds. Answer: B. 15 compressions to 2 ventilations. The concept tested is the proper technique for pediatric CPR, which varies based on the number of rescuers. The key phrase 2-rescuer team and 7-month-old infant are the necessary clues for determining the correct ratio. In 2-rescuer infant or child CPR, the compression to ventilation ratio is 15, 2 to minimize interruptions to chest compressions while still providing adequate ventilation. The 30:2 ratio is used for single rescuer adult, child, and infant CPR as well as 2-rescuer adult CPR. A good way to remember this is that when 2 people are present for a child, they can afford to take turns more frequently, allowing for more continuous compressions and minimizing rescuer fatigue. Question 12. A 60-year-old type 2 diabetic patient is severely dehydrated, has a blood glucose reading of 880 milligrams per deciliter, and an absence of Kussmaul respirations or fruity odor to the breath. This clinical picture is most consistent with
A.
diabetic ketoacidosis,
B.
hyperglycemic hyperosmolar non-ketotic syndrome, HHNS,
C.
hypoglycemia,
D.
adrenal crisis. Answer: B. hyperglycemic hyperosmolar non-ketotic syndrome, HHNS. This question requires the student to differentiate between the 2 major hyperglycemic emergencies. The critical keywords are severely dehydrated, blood glucose of 880 milligrams per deciliter, extremely high, and the absence of Kussmaul respirations or fruity breath. HHNS is characterized by profoundly elevated blood glucose, often greater than 600 milligrams per deciliter, and severe dehydration, but the patient is not typically producing a large amount of ketones, thus avoiding the characteristic deep, rapid Kussmaul breathing or the fruity breath associated with DKA. The core guideline is that the lack of ketone production is the main clinical distinction between HHNS and DKA. Question 13. A 45-year-old male has full-thickness burns covering his entire left arm and partial-thickness burns covering his entire back. Using the rule of 9s for an adult, what percentage of total body surface area, TBC, is burned?
A.
18%.
B.
27%.
C.
36%.
D.
45%. Answer: B. 27%. The concept being tested is the application of the rule of 9s to rapidly estimate total body surface area, TBC, in adult burn patients. The keywords are rule of 9s, entire left arm, and entire back, which require applying the standard adult percentages. In the adult rule of nines, the entire arm is 9% and the entire back is 18%. Adding these two together, 9% plus 18%, gives a total TBSA of 27%. This calculation is critical for determining the need for advanced burn center transport and for initiating appropriate fluid resuscitation using the Parkland formula. Question 14. During bag valve mask, B, ventilation of an unconscious apneic adult patient, you note increasing resistance when squeezing the bag and the abdomen appears to be distending. This is most likely caused by
A.
Complete foreign body airway obstruction.
B.
Excessive ventilatory rate and volume.
C.
Bronchospasm or COPD exacerbation.
D.
Pneumothorax. Answer: B. Excessive ventilatory rate and volume. This question tests the understanding of proper BVM technique and the complications of poor technique. The keywords are increasing resistance combined with abdomen appears to be distending. When a rescuer ventilates too quickly, too forcefully, or with excessive volume, air is diverted into the esophagus and fills the stomach, causing gastric distension, which leads to resistance and increases the risk of vomiting and aspiration. Gastric distension makes it harder to deliver air to the lungs, increasing resistance, so the solution is to slow the rate and deliver just enough volume to cause visible chest rise. The important guideline is to always deliver slow, gentle breaths over 1 second to avoid filling the stomach with air. Question 15. A patient is found in cardiac arrest. The cardiac monitor shows pulseless electrical activity, PA. After securing the airway and obtaining vascular access, the most critical intervention to improve the patient's outcome is
A.
Administering immediate synchronized cardioversion.
B.
Rapidly administering 2 ampoules of sodium bicarbonate.
C.
Administering epinephrine and aggressively searching for and treating reversible causes.
D.
Preparing for immediate transcutaneous pacing. Answer: C. Administering epinephrine and aggressively searching for and treating reversible causes. This concept addresses the management of pulseless electrical activity, PA, within the cardiac arrest algorithm. The keywords are pulseless electrical activity and most critical intervention. While epinephrine is the primary drug for PEA, the key to PEA survival is identifying and treating the reversible causes, often summarized by the H's and T's, e.g., hypovolemia, hypoxia, tamponade, tension pneumothorax. Since PEA represents a profound failure of the heart's mechanical pump, simply administering medication without fixing the underlying cause is rarely effective. Remember that in PEA, the rhythm is good, but the pump is bad, so you must find and fix the reason why the pump failed. Question 16. A 68-year-old patient woke up with right-sided weakness and slurred speech 30 minutes ago. He is a candidate for fibrinolytic therapy, clot buster. What is the absolute most time-sensitive treatment intervention that EMS must focus on for this patient?
A.
Rapid intravenous access and administration of 50% dextrose.
B.
Immediate initiation of the Cincinnati Pre-Hospital Stroke Scale.
C.
Early notification to the receiving hospital to activate the stroke team.
D.
Rapid control of hypertension to prevent hemorrhagic conversion. Answer: C. Early notification to the receiving hospital to activate the stroke team. This question tests the recognition of a time-critical neurological emergency and the operational priorities of EMS. The key phrase is candidate for fibrinolytic therapy, indicating a suspected acute ischemic stroke where treatment is highly time-dependent. The single most effective action EMS can take to expedite care is to provide early, accurate pre-arrival notification to the receiving hospital so that all necessary in-hospital resources, CT scanner, neurologist, etc., can be immediately mobilized. While the assessment and patient care steps are crucial, maximizing the speed of the hospital's response through early notification is the ultimate time saver for a stroke patient. Question 17. A healthy 25-year-old marathon runner collapses at the finish line on a hot, humid day. He is unconscious, his skin is hot and dry, and his core temperature is 105, 9 degree F, 41, 1 degree C. This presentation is most consistent with
A.
non-exertional, class C, heat stroke,
B.
heat exhaustion,
C.
exertional heat stroke,
D.
pyrexia of unknown origin. Answer: C. Exertional heat stroke. The concept is differentiating between types of heat emergencies, specifically between the two types of heat stroke. The keywords are marathon runner, collapses, and hot and dry skin with an extremely high core temperature. Exertional heat stroke occurs in young, otherwise healthy individuals due to strenuous exercise, overwhelming the body's thermoregulation. Non-exertional heat stroke typically affects sedentary or elderly individuals during heat waves due to environmental exposure. Therefore, the combination of physical exertion and critical signs of heat stroke points directly to the exertional type. A simple way to remember this is that an athlete getting heat stroke in the summer is likely exertional, while a grandparent found unresponsive in a non-air-conditioned apartment is likely non-exertional. Question 18. You are treating a patient with excited delirium syndrome who is displaying extreme agitation and superhuman strength, posing a threat to himself and others. Chemical restraint is indicated. Which medication and route is the current consensus recommendation for rapid and effective sedation?
A.
Midazolam vs. D. 5 mg intramuscular, IM.
B.
Haloperidol, Heldol, 10 mg intravenous, 4.
C.
Ketamine 4 mg per kilogram intramuscular, IM.
D.
Diazepam Valium, 10 mg oral, PO. Answer: C. Ketamine 4 mg per kilogram intramuscular, IM. This question tests current protocols for the chemical restraint of excited delirium syndrome, XD. The keywords excited delirium syndrome, extreme agitation, and chemical restraint point to the need for rapid, profound sedation. Ketamine is the current evidence-based preference for XDS because the intramuscular route is safer and quicker to administer in a struggling patient, and the dissociative effect is reliable and rapid-acting. Haloperidol is slow and has a risk of cardiac side effects, and oral benzodiazepines are not practical for an actively fighting, acutely psychotic patient. A practical tip is that for a patient exhibiting XDS, the primary goal is a rapid, safe sedation, and IM ketamine is the most reliable tool to accomplish this goal. Question 19. A patient has sustained a high cervical spine injury, C5 or above, from a diving accident. Assessment reveals an adequate ventilatory rate, but poor tidal volume, blood pressure of 80/50, and a heart rate of 50. The patient is warm and dry below the level of the injury. This clinical picture is characteristic of
A.
hypovolemic shock,
B.
neurogenic shock,
C.
obstructive shock,
D.
cardiogenic shock. Answer: B. Neurogenic shock. This question requires differentiating various types of shock based on clinical presentation following trauma. The keywords high cervical spine injury, BP 80/50ths, HR 50, bradycardia, and warm and dry skin are the classic signs of neurogenic shock. This type of shock occurs when spinal cord damage disrupts the sympathetic nervous system's control of blood vessels and the heart rate, causing vasodilation, warm skin, and loss of sympathetic tone, resulting in a low heart rate and low blood pressure. Unlike hypovolemic shock, where the body compensates with tachycardia and cool skin, the bradycardia and warm skin are the definitive clues for neurogenic shock. Question 20. You are managing a patient with complete upper airway obstruction due to massive facial and laryngeal trauma. Attempts at intubation and visualization have failed, and the patient is rapidly deteriorating. The paramedic's most appropriate next step is
A.
attempting needle cricothyroidotomy, CRIC, using a large-bore angiocatheter.
B.
Immediate surgical cricothyroidotomy.
C.
Repeated Sellick's maneuver with aggressive suctioning.
D.
Immediate high-flow oxygen via a non-rebreather mask. Answer: B. Immediate surgical cricothyroidotomy. This question tests the management of the can't intubate, can't oxygenate scenario, which is a rare but critical airway event. The keywords complete upper airway obstruction, massive facial and laryngeal trauma, and intubation failed indicate the need for a definitive, below-the-cord airway. A surgical cricothyroidotomy is the definitive, rapid, and primary rescue airway technique for an adult with a complete obstruction when all other means have failed. Needle cricothyroidotomy is generally a temporary measure that is not recommended for definitive care in adults due to inadequate ventilation, while high-flow oxygen will not help a completely obstructed airway. Question 21. A 24-year-old female presents with severe, localized lower quadrant abdominal pain radiating to her shoulder, and she reports missed menstrual periods. She is pale, slightly diaphoretic, and her blood pressure is 98/60. This presentation is highly suggestive of
A.
pelvic inflammatory disease Ped,
B.
acute appendicitis,
C.
ectopic pregnancy,
D.
ovarian torsion. Answer: C. Ectopic pregnancy. This question focuses on recognizing a time-critical gynecological emergency based on the classic signs. The keywords are severe, localized lower quadrant abdominal pain, radiating to her shoulder, and missed menstrual periods. The abdominal pain coupled with signs of hypoperfusion, pale, BP 98/60, suggests internal hemorrhage, and shoulder tip pain, Kerr's sign, is a classic indicator of diaphragmatic irritation from internal blood, making a ruptured ectopic pregnancy the most likely diagnosis. PID and appendicitis cause localized pain, but are less likely to cause sudden, significant hypoperfusion or shoulder pain. Question 22. During a mass casualty incident, MCI, a patient is found unresponsive, not breathing, and after repositioning the airway, they still do not spontaneously breathe. Using the START triage system, what triage category should this patient be assigned?
A.
Red, immediate.
B.
Yellow, delayed.
C.
Green, minor.
D.
Black, deceased/expectant. Answer: D. Black, deceased/expectant. This question tests the application of the simple triage and rapid treatment START method used in mass casualty incidents. The critical keywords are unresponsive, not breathing, and the key triage step is that a patient who fails to breathe after an airway opening maneuver is immediately classified as black. The underlying principle of the START system is to focus resources on the patients who have the highest chance of survival with immediate care. Ready? A non-breathing patient who does not respond to a simple airway maneuver is unlikely to survive, so they are tagged black to avoid diverting resources from salvageable patients. Question 23. A 55-year-old diabetic male is complaining of only vague malaise and mild epigastric discomfort, with no chest pain or shortness of breath. His ECG shows classic ST segment elevation. This patient's atypical presentation is most commonly due to
A.
a delay in seeking medical attention,
B.
autonomic neuropathy interfering with pain perception,
C.
the presence of a chronic lung disease like COPD,
D.
his advanced age and reduced activity level. Answer: B. Autonomic neuropathy interfering with pain perception. This question addresses the unique presentation of myocardial infarction, MI, in specific patient populations, particularly those with diabetes. The keywords are diabetic male, vague malaise and mild epigastric discomfort, and no chest pain, which describe an atypical or silent MI. Long-standing diabetes often causes autonomic neuropathy, a type of nerve damage that affects the body's ability to sense pain, thus preventing the patient from experiencing classic chest pain. Angina? Therefore, EMS providers must have a high index of suspicion for MI in diabetic patients with vague symptoms like nausea or generalized weakness. Question 24. You discover a significant error, e.g., incorrect medication dose on a completed and submitted pre-hospital care report, PCR. What is the appropriate, ethical, and legal way to correct this error?
A.
Erase the original entry completely and rewrite the correct information.
B.
Draw a single line through the incorrect entry, write the correct information next to it, and initial and date the change.
C.
Create a new PCR and destroy the original report.
D.
Use correction fluid or an opaque tape to cover the incorrect entry. Answer. B. Draw a single line through the incorrect entry, write the correct information next to it, and initial and date the change. This question tests the essential legal and professional requirement for proper documentation correction. The key concepts are accuracy, transparency, and maintaining the integrity of the medical record, so the original error must remain legible. The proper procedure is to never obscure or delete the original entry, but to correct it with a single line, thus leaving the incorrect information readable, and then authenticate the change with initials and the date. This method ensures that the patient care report is a defensible legal document that clearly shows when and how the entry was modified. Question 25. A 30-year-old male is found unresponsive on the floor. He has constricted, pinpoint, pupils, a respiratory rate of 6 shallow breaths per minute, and his skin is cool and clammy. This clinical picture is known as the triad of
A.
sympathomimetic overdose,
B.
opioid overdose,
C.
cholinergic crisis,
D.
anticholinergic poisoning. Answer. B. Opioid overdose. The concept tested is the immediate recognition of a toxicological emergency, specifically an opioid overdose. The keywords are unresponsive, constricted pinpoint pupils, and respiratory rate of 6 shallow breaths per minute, which together form the classic opioid triad. The triad consists of altered mental status, unresponsiveness, respiratory depression, and meiosis, pinpoint pupils. This immediate recognition is vital because it triggers the most critical intervention, administration of naloxone, which can reverse the life-threatening respiratory depression. Question 26. In pediatric trauma patients, a tension pneumothorax can develop rapidly and is often difficult to detect. A clinical sign unique to pediatric patients that can be an early indicator of a pneumothorax is
A.
distended neck veins,
B.
tracheal deviation,
C.
increased heart rate followed by sudden bradycardia, D. paradoxical chest wall movement. Answer. C. Increased heart rate followed by sudden bradycardia. This question tests a high-level concept regarding the unique physiological response of pediatric patients to shock and respiratory compromise. The keywords are pediatric trauma, tension pneumothorax, and early indicator. Unlike adults who will remain tachycardic for a long time, children initially respond to hypoxia with an increased heart rate, but they rapidly crash into bradycardia when their compensatory mechanisms fail. Therefore, the sudden onset of bradycardia in a distressed or injured child is often a pre-terminal sign that necessitates immediate, aggressive intervention such as needle decompression for a suspected tension pneumothorax. Question 27. What is the most accurate guidance for delivering a tidal volume when ventilating an apneic adult patient with a bag valve mask? BVAM?
A.
Squeeze the entire bag forcefully every 5 seconds.
B.
Deliver only a small puff of air to prevent gastric distension.
C.
Deliver a volume over 1 second that results in visible chest rise.
D.
Deliver a volume of 10 to 12 ml/kg of the patient's estimated body weight. Answer. C. Deliver a volume over 1 second that results in visible chest rise. This question focuses on the proper technique for manual ventilation, a core EMT and paramedic skill. The keywords most accurate guidance and tidal volume refer to the current standard of care for BVM ventilation. The current best practice is to provide just enough volume to achieve visible chest rise, delivered over 1 second, which minimizes the risk of gastric inflation and pressure-related lung injury, barotrauma. Forceful, full bag squeezes deliver excessive volume, while a small puff is often insufficient to fully oxygenate the patient. Question 28. A patient has a suspected infection. Vitals include HR112, RR26, SPO 293% on room air, and a temperature of 101.5 F, 38, 6 C. The initial finding that most strongly suggests the possibility of systemic sepsis is
A.
the mild hypoxia indicated by the SPO2 of 93%.
B.
The respiratory rate greater than 22 breaths per minute.
C.
The documented fever greater than 101.0 F.
D.
The heart rate greater than 110 beats per minute. Answer: B. The respiratory rate greater than 22 breaths per minute. The concept being tested is the quick assessment for sepsis using validated screening tools such as QSOFA, Quick Sequential Organ Failure Assessment. The keyword most strongly suggests refers to the current emphasis on easily measurable indicators of organ dysfunction. A respiratory rate of 22 breaths per minute or higher is a key component of the QSOFA score because it indicates a change in mentation and/or a drop in blood pressure, suggesting that the infection is negatively affecting a vital organ system. While fever and tachycardia are part of the older SIRS criteria, a high respiratory rate is a stronger predictor of mortality and organ failure in the early stages of sepsis. Question 29. A patient with a transvenous pacemaker presents with an EKG showing a pacing spike followed by no QRS complex. The patient is symptomatic and hypotensive. This EKG finding is known as
A.
failure to sense,
B.
failure to pace,
C.
failure to capture,
D.
oversensing. Answer: C. failure to capture. This question tests the recognition and interpretation of a pacemaker malfunction on an EKG. The keywords are pacing spike followed by no QRS complex, which means the electrical impulse was successfully delivered, but it did not cause the heart muscle to depolarize, contract. Failure to capture is the term for this event and is a life-threatening problem that requires immediate clinical intervention, often involving increasing the output of the pacemaker or preparing for transcutaneous pacing. Failure to pace would be the absence of spikes, and failure to sense would involve pacing spikes falling randomly onto the patient's intrinsic rhythm. Question 30. You are extricating a patient whose leg has been pinned under heavy machinery for over 4 hours. Upon successful release, the patient is noted to have a pale, pulseless extremity. The most immediate and critical concern is the potential for
A.
hemorrhagic shock from reperfusion injury,
B.
sudden onset of hyperkalemia and acidosis from crush syndrome,
C.
direct pressure compartment syndrome,
D.
fat embolism and pulmonary compromise. Answer: B. Sudden onset of hyperkalemia and acidosis from crush syndrome. The concept is recognizing and managing the immediate post-release complications of prolonged limb entrapment, known as crush syndrome. The key phrase is pinned for over 4 hours and upon successful release. When the crushed limb is released, the massive volume of accumulated cellular toxins, particularly potassium, leading to hyperkalemia, and lactic acid, leading to acidosis, floods the central circulation, which can cause immediate, fatal cardiac dysrhythmias and acute renal failure. Therefore, the priority of care is to prevent this cascade by aggressively managing for fluids and medications before the limb is released. Question 31. A 10-year-old child is found to have multiple bruises of varying ages and locations on his back and extremities, which are inconsistent with the mechanism of injury described by the caregiver. In the pre-hospital setting, the EMS provider's primary ethical and legal obligation regarding suspected child abuse is to
A.
immediately confront the caregiver about the suspected abuse.
B.
Document the findings accurately and report the suspicion to the appropriate state agency or emergency department staff.
C.
Only report the findings if the patient is symptomatic or critically injured.
D.
Refuse to transport the child until a police officer investigates the scene. Answer: B. Document the findings accurately and report the suspicion to the appropriate state agency or emergency department staff. This question tests the EMS provider's legal obligations regarding mandatory reporting. The keyword, primary ethical and legal obligation, highlights the non-negotiable duty to report suspected abuse, regardless of personal comfort or the child's immediate condition. EMS providers are mandatory reporters in all states, and the correct procedure is to objectively document all findings and observations, and then notify the receiving facility personnel or the appropriate local authorities as mandated by local protocol. It is never the EMS provider's role to investigate or confront, only to report. Question 32. A 35-year-old patient who was treated for anaphylaxis with epinephrine and diphenhydramine is now resting comfortably. Approximately 6 hours after the initial reaction has resolved, the patient reports a sudden return of shortness of breath and hives. This is known as
A.
refractory anaphylaxis,
B.
biphasic reaction,
C.
protracted anaphylaxis,
D.
delayed allergic response. Answer: B. Biphasic reaction. This question introduces the concept of a biphasic reaction, which is a key advanced topic in allergy and immunology management. The key words are initial reaction has resolved, followed by a sudden return of shortness of breath and hives hours later. A biphasic reaction is characterized by a second, potentially severe reaction that recurs after the initial symptoms have cleared, typically without re-exposure to the allergen. This phenomenon is why all anaphylaxis patients should receive close observation, and it is crucial to recognize that the danger is not necessarily over once the initial symptoms are treated. Question 33. You are attempting to remove a foreign body from the airway of an unresponsive adult patient. Direct visualization with a laryngoscope has been achieved, and the foreign body is visible in the hypopharynx. What is the most appropriate next step?
A.
Perform blind finger sweeps until the object is dislodged.
B.
Push the foreign body further down into the trachea to create a more stable seal.
C.
Attempt removal using McGill forceps under direct visualization.
D.
Immediately stop the procedure and initiate back blows and chest thrusts. Answer: C. Attempt removal using McGill forceps under direct visualization. This question tests the correct procedure for foreign body airway obstruction management when the object can be seen. The critical keywords are direct visualization with a laryngoscope and foreign body is visible. When the object is visible, the only correct technique is to use McGill forceps to gently grasp and remove the object under continuous, direct visualization, as blind procedures risk pushing the object deeper into the airway. Blind finger sweeps are no longer recommended in adults because of the risk of causing complete obstruction, and stopping the procedure would waste critical time. Question 34. When transmitting critical information such as a medication name or street address over the radio, what protocol should the EMS provider utilize to ensure maximum clarity and accuracy?
A.
Simply repeat the word twice at a slower pace.
B.
Spell out the word using the standard NATO phonetic alphabet, e.g., A as in alpha, B as in Bravo.
C.
Use common letter identifiers only when the word is complicated.
D.
Ask the receiving dispatcher to repeat the word back before proceeding. Answer: B. Spell out the word using the standard NATO phonetic alphabet, e.g., A as in alpha, B as in Bravo. This question addresses the fundamental operational requirement of clear and effective radio communication. The keyword maximum clarity and accuracy points to the standardized method used across EMS, police, and military services. The standard is to use the NATO phonetic alphabet to spell out potentially confusing words, which virtually eliminates miscommunication caused by poor reception, background noise, or similar-sounding letters, e.g., M versus N. This simple protocol prevents potentially life-threatening errors, such as confusing a drug name or an address. Question 35. A patient who is unconscious following a motor vehicle collision requires immediate airway management. The patient is found slumped over the steering wheel, indicating a high potential for cervical spine injury. Which maneuver is the most appropriate initial method for opening this patient's airway?
A.
Head tilt, chin lift maneuver.
B.
Oropharyngeal airway, OP insertion.
C.
Nasopharyngeal airway, NP insertion.
D.
Jaw thrust maneuver. Answer: D. Jaw thrust maneuver. The concept is selecting the appropriate airway maneuver based on the mechanism of injury. The keywords are unconscious, motor vehicle collision, and high potential for cervical spine injury. In any suspected spine injury, the jaw thrust maneuver is the mandatory initial choice because it provides an open airway while minimizing movement of the neck and spine, maintaining inline stabilization. The head tilt, chin lift maneuver is generally avoided in trauma because it can extend the neck and potentially worsen a spinal cord injury.